Thank you so much for the introduction, and thanks also for the invitation to share. It's great to see some familiar faces and colleagues on the call. And as we were gathering, I was just sort of reminiscing how it was this time last year. I was pleased to be a part of the mHealth Training Institute of the 2023 cohort. And it was this time last year that we were kicking off all of our introductions and small group sessions and whatnot. So I had to admit that I was a little jealous not to kind of be reliving that again. So as was mentioned, I'm based at Wake Forest University School of Medicine. We're in North Carolina on the East Coast, so 3 o'clock is a little bit of my afternoon slump, so glad to be having something active to do during that time. And I'm a faculty member in implementation science and geriatrics. And my hope today really is to kind of offer some big picture pointers and guidance around some leading implementation science principles, theories, models, and frameworks, really as an opportunity to kind of give this as a resource to early career faculty, trainees, mid-career faculty, teams that are looking to kind of think, how do I get my innovation into practice? And more importantly, how do I get it to stay there? So formally, the title of my talk is Leveraging Implementation Science to Develop and Scale a Patient-Centered Platform to Support Aging in Place. I think unless there are kind of technical difficulties or snafus, welcome you to kind of interrupt me and let me know, but otherwise, there should be plenty of time for questions and conversations at the end. So I like to actually start out with my kind of acknowledgements of all of my collaborators, because so rarely do we get time to kind of acknowledge these folks towards the end. So although I'm on the East Coast, did get to spend a good number of years in sunny Los Angeles and really started my career there at the Greater Los Angeles VA and UCLA. Moved across the country and continued my VA collaborations at the Durham VA and Duke University School of Medicine, and continue those collaborations today. And now, as was mentioned, I'm at Wake Forest University School of Medicine. I have a fabulous research team. Without these folks, none of this work really would be possible. They're the ones who are calling and recruiting patients, analyzing data, and they have spent countless hours in the past few weeks and months transcribing exit interviews and patient interviews. So incredibly grateful to them as well. A combination of funding from different federal sources as well as institutional sources. And again, just kind of like to acknowledge the opportunity that brought me here and led to this innovation, which was a participant in last year's mHealth Training Institute. So today's objectives, as I mentioned, are really to provide an introduction to key implementation science principles within the context of digital health and mHealth. So some of those principles are that implementation is multi-level and it's a dynamic process. The more that we can engage with key individuals early and often, the more likely we are to successfully promote our products or our tools or our innovations and kind of promote scalability and sustainability over time. Throughout this presentation, I'll highlight one unique pathway to developing and scaling an mHealth tool for older adults. So we were really fortunate. Our university, our School of Medicine, launched a program called Launch. There was an innovation incubator and sort of accelerator program. We were the inaugural winners. And this program was really kind of how do we had a digital health tool or mHealth tool as our innovation, but how do we get this innovation into practice quickly and effectively? So we talked about adapting an evidence-based tool for widespread integration into a healthcare system. We did that in collaboration with operations teams and clinical partners. And through those collaborations, we were able to really plan for dissemination, scalability, and sustainability. So that case example, that kind of this unique pathway is PATINA, which stands for Patient Integrated Assessment. And we really think about it as a comprehensive platform to support aging in place. And I mentioned we should have plenty of time for questions and conversations at the end. So I thought it would be helpful just to sort of lay the foundation, level set a little bit, to think about what is implementation science. The phrase implementation is thrown out quite a bit. It's certainly been, for any of us who work within the kind of public health realm, a term that we're probably most familiar with through things like the RE-AIM framework, which is an evaluation framework. But I think implementation is so much more. Implementation science, more formally, is the scientific study of methods used to adopt and integrate evidence-based practices into routine care. It's focused on exploring how and under what conditions evidence-based practices or interventions are successfully integrated into routine care. And it's really the use of rigorous methods. There is a strong and kind of elaborate depth and breadth set of methods to adapting and scaling an evidence-based intervention from one setting to another. So as an implementation scientist, I get approached all the time, particularly by teams who have an innovation, whether it's a kind of in-person behavioral intervention, a digital health tool, a change in workflow, that these teams have tested. And then once it's tested, once it's gone through the RCT, then it's sort of, oh, how do we get this into practice? That's great. I love being approached by those teams. I love thinking about, here we have a strong body of evidence. What's the next step? What I really, really love even more than that, and what I encourage folks who are listening to think about, is how can you involve an implementation scientist, methodologist early in your process, but often and throughout your process. And some of those benefits will include understanding what it takes, the resources, the staff, the training to translate your digital health, your mHealth program or product or tool into practice, to identify potential barriers to scale and spread early so that you can address those barriers before you get to that late stage translation phase. To explore the extent to which your innovation is aligned with end users, patients, providers, payers. We spend a lot of money, we spend a lot of federal dollars, foundational dollars, developing our innovations. So if we're going to spend all of this money, chances are we'd prefer that this program can actually be used, can be reimbursed. Again, it can be integrated into the healthcare ecosystem. And so part of that kind of benefit of engaging early and often with an implementation scientist or methodologist is to really begin evaluating and optimizing cost throughout your process. I could probably spend this whole entire hour with you talking about theories, models, and frameworks, but that's not the focus of today's talk. When we think about theories, models, and frameworks, I've lost count of how many there are at this point. We tend to think about them in terms of implementation science as falling into one of three categories. So determinants, process, and evaluation. Determinants is thinking about those implementation barriers and facilitators, what's contributing both to the problem, but the solution, and kind of the interaction of your problem and solution with your implementation setting. Process, we can't just say, I've got an effective program, let me walk into a primary care clinic and, within a week's time, a month's time, this clinic will be using it. There's a process, a science, a strategy, just as I highlighted in the definition of implementation science, to getting your quote thing or your innovation into practice. And of course, evaluation. So here I already mentioned RE-AIM a little bit. If you take one thing away from the presentation today, please remember that RE-AIM is an evaluation framework. It is really, it's been around for a number of decades. It's an incredibly valuable evaluation framework, but implementation is just one piece of that framework. So there are a number of different outcomes that we're often interested in when it comes to implementation. Things like acceptability or feasibility are probably kind of familiar terms for those of us who develop interventions. But there are other common kind of outcomes: adoption, appropriateness, penetration, sustainability. And I really encourage folks to search for some of these different theories, models, and frameworks and learn a little bit more about them. One fabulous resource is the University of Washington Implementation Science Resource Hub. Again, I could spend the whole session on these frameworks, also on resources. So there are a good number of resources to help you learn about theories, models, and frameworks, and to also pick one. I encourage you to do a little bit of searching on your own. So one of the big principles of implementation and implementation science is that it's multi-level. Many of you have probably heard or even used the CFR, which is the Consolidated Framework for Implementation Research. This is a comprehensive framework, a multi-level framework that was really the brainchild of an interdisciplinary team at the Ann Arbor VA and the University of Michigan. CFR 2.0 just came out within the past few years. And I won't go through the different there's a lot going on, a lot of circles, arrows, boxes, dotted lines, solid lines. The key takeaway here is that implementation is multi-level. At the bottom of the figure, we have individuals. So this includes individuals delivering the innovation or intervention, as well as those receiving the innovation or intervention. The inner setting for someone like me who typically works within primary care or clinics, this would be that clinic or that kind of service line. And then the outer setting, again, just for example's sake, for someone like myself, this is often the healthcare system and the larger kind of payer environment. Insurance for my population of older adults, we're typically thinking about Medicare. The other key principle of implementation is that it's dynamic and iterative. Another key framework that I think is really beneficial and can have a lot of particular applications in mHealth is the EPIS framework, the Exploration, Preparation, Implementation, and Sustainment framework. So the key takeaway from this figure is if you look at the circle going around kind of the outside of the figure, there are these unique phases or processes: exploration, preparation, implementation, and sustainment. And for the most part, these are bi-directional arrows. This could be a circle, it could be linear. However you lay out these phases or processes, the key takeaway is that it's bi-directional. At the center of the figure, you see many kind of similar elements to the CFR. So this idea of inner context and outer context. Again, implementation is multi-level, and here we see that it's dynamic and iterative. For those of you who develop behavioral interventions, we also see this kind of dynamic iterative process, or the principle of that nature of those kind of dynamic iterative processes represented in the NIH stage model. So the idea of we can build something, we can test it, but we're always kind of thinking about how to optimize and refine our programs or our implementation strategies. So as I mentioned, there's a science behind implementation, thinking about how do we get Jeff Curran. I haven't included kind of references to his work here. He has the best language, I think, of anyone in the field, where it's sort of your innovation is your thing, and the strategies are how you get your thing into practice. So implementation strategies can be discrete, meaning a single strategy, multifaceted, 2 or more strategies, a bundle. And these are activities that are enacted to support adoption, integration, and sustainment of evidence-based programs into routine practice. Again, implementation is multi-level and it occurs across different phases or processes. So most often, different strategies are needed at different levels of implementation and are across those different phases or processes. Our settings are diverse. Some of us work in primary care, some in surgery, some in specialty care, some in schools, some in communities. We're certainly not necessarily limited to healthcare facilities. So one strategy or set of strategies that works in one setting might not be appropriate or a good fit for another. So thinking about how our implementation strategies or activities are aligned with an organization's context, culture, and capacity can really kind of help improve our success of adoption and sustainment of our programs. So Byron Powell, who is one of the leading kind of brain trusts behind implementation strategies, I was excited to see him on the schedule as presenting as part of this year, the 2024 mHealth Training Institute. He has some seminal work that I guess, gosh, looking at the date, almost 10 years now, the expert recommendation for implementing change, or ERIC strategies or taxonomy. This is a list of, I think it's 83 different implementation strategies. And again, these are the activities that are done or used to get our thing, our innovation, into practice. There's been some subsequent work to try and kind of better categorize those ERIC strategies into, or excuse me, collapse them into kind of these overarching categories. And that's what you see on the screen in front of you. So I think, you can look across the screen and kind of think, oh, okay, I've used some of these. I've used data experts in terms of tailoring to context, training and educating stakeholders. For those of us who work in healthcare, supporting clinicians. This could be in the school, supporting teachers, educators. Changing infrastructure is a little bit more difficult, but something I know we do on the VA side of things at times. Developing stakeholder interrelationships. Again, these are categories of activities or strategies that we within implementation science think about how can we use these to support adoption and sustainment of an innovation into practice. As I mentioned already, it's important to really match your strategies to your different levels and different processes. So this is just an example. These are some of the strategies we actually use in some of our projects, and you'll see that there might be similarities across kind of levels, the individuals using the innovation or intervention, those delivering it, clinic managers, higher level service line chiefs or health system leaders. And again, just thinking about our strategies will vary across our levels and not shown here across our different phases or the kind of process of implementation. And just in kind of closing, in terms of our key principles of implementation science, I've mentioned several times, I do a lot of my work in the VA healthcare system. This is a national healthcare system with more than 142 or maybe 142, give or take, is our current number of VA medical centers or large hospitals. They're also community-based outpatient clinics. We often say in the VA, and this could be true in any setting, healthcare, schools, states, you name it, kind of if you've seen one, you've seen one. And the things that we think about that can impact, again, kind of our scale and our spread of our innovation are one, the organizational characteristics. So what is a clinic or a school's or a school system's capacity? How ready are they to change? What sort of competing demands do they have? Is there leadership support for change or for your particular innovation? What sort of knowledge and skills are present among the providers or the staff or the individuals who might be delivering your innovation? Again, a little bit of these examples are really rooted in my own experience working in healthcare, but our patient characteristics can really impact how an intervention or innovation is really adopted or sustained into practice. Again, I work a lot in primary care, but we are a growing healthcare system. Our patients within our metropolitan regions are quite different than our patients in our more urban regions, or excuse me, our more rural regions. And so how do those different clinical and demographic characteristics impact what I'm taking into practice? A lot of us have been trained, in these kind of tightly controlled RCT experimental conditions. And there is absolutely a time and a place for things like high fidelity, tightly controlled experimental conditions. On the flip side of that, there's also, we kind of, especially within implementation, are maybe a little bit more aware of the benefit of adaptation. of the fact that adapting an intervention or innovation or the strategy can actually be a good thing. It can mean enhancing the fit between our program and the population or the setting that we're implementing in. And so I think, what I encourage folks, again, absolutely a time and a place for the RCT, but sort of when you're going out into the real world, nothing's going to go as planned. So other big takeaway, you have to be, if you're going to implement in the real world, you have to be ready and willing and able to let it all go and know that that's okay. That could probably be a separate talk for another time. So again, kind of when things start to go awry, when you're faced with a lot of different potential changes or adaptation, coming back to kind of the needs and preferences of your end users. Is your innovation or intervention aligned with their needs and preferences? And if so, maybe if adapting means that you'll have better alignment, maybe the benefits of adaptation outweigh the potential kind of challenges or consequences. The one last resource I'll leave with you in terms of sort of leading implementation science resources and principles is the framework for reporting adaptations and modifications. So I realize this is a very busy slide. Again, we will not go into depth with it. I'm presenting it here to sort of give you something to kind of pique your interest and maybe take a look at. The idea here is that when we do adapt, that's good. It's certainly not bad. We have to get out of that kind of mindset. But really taking note of both planned and unplanned changes or adaptations, identifying when it occurs, what the rationale was, being specific in kind of what we changed, adapted, or modified, so that we can track those over time and we can really kind of go back at the end of our implementation phase or trial and really start to look at what adaptations were beneficial and most impactful. So developing and scaling an innovation. I don't know, maybe folks are listening in because they're really excited about aging in place. I certainly love the older adult population and hope there's some other folks listening in who also feel the same. So how do I, as an implementation scientist, I started my career as a behavioral interventionist. That is my bread and butter. I love to develop in-person, digital, individual, group-based interventions, primarily for sleep and activity. But how now, as I work more in implementation science, how do I think about developing and scaling an innovation? So one, what are the gaps? What are its determinants? What are potential solutions? How can I, in the process, engage key individuals and end users to explore needs, preferences, and context? I personally, as an implementation scientist, prefer to think about, well, what's going to happen 5, 10 years down the road? How can I think about designing for dissemination, long-term scalability and sustainability from the start of my design and development process? And to do that, I really champion the idea of cultivating collaborations with key clinical and operations partners from the very beginning. If not step 3, step 1, or step 0 before you even get started. There's, of course, the process of developing and refining your innovation or your mHealth tool. So hopefully folks don't drop off now. I hate to spoil the surprise. I won't talk a lot about the technical specifics of our program. I'm certainly happy to take questions or talk with attendees at another time. But of course, there's this more kind of traditional process of developing and refining an innovation. For us, that was our PATINA tool. And then moving into evaluation of that tool or innovation, as well as, again, the tools, resources, and supports needed for its adoption and sustainment. So I thought it would be helpful just to kind of bring these principles back and kind of map them onto these different steps. So in the top right-hand corner of your screen, don't mean for you to read from that kind of small picture, but that is the EPIS framework. So again, this is the idea that implementation occurs across phases and it's dynamic. and an iterative process. So those phases are exploration, preparation, implementation, and sustainment. So in my work, I'm, I guess, a mixed methods supporter, champion, certainly use it a lot in my work. But one question just quickly that I get a lot as an implementation scientist or consultant is, how do I know when my innovation is ready, or what data can I look at? One thing I won't talk about is, but what we do is look a lot at our existing data sets. We pull data from the medical record. We look at old interventions and kind of process notes. Look at old papers, even a kind of training protocol for an RCT of an intervention can tell you a lot about implementation, thinking creatively about when we're thinking about identifying potential solutions, where to look for that data. Throughout, I think the takeaways from this slide are we use a lot of mixed methods, qualitative interviews, co-design activities. We also have informal conversations with health system leaders, with community partners and programs. What's happening in Medicare Advantage plans, what changes are coming down the pipe. And of course, steps 4 and 5, we have the more traditional technical development, usability testing and refinement stages. And then in implementation and sustainment, thinking about pilot trials, embedded work, and pragmatic studies. So step 1, identifying the gap, its determinants, and beginning to identify potential solutions. And what presentation would be complete without the dog barking at some sort of delivery person. So again, I mentioned I'm in the state of North Carolina, and that this work was really championed through an innovation accelerator incubator program. The charge of that particular program was how we think about supporting our patients in their health at home. So our particular team, it's myself, an exercise physiologist, an anesthesiologist or pain physician. We're really interested in how can we keep our older patients at home. So in our state, in less than 5 years, 1 in 5 North Carolinians will be 65 years or older. And for many of these patients, as well as their caregivers, providers, policymakers, aging in place is really a priority. Well, in order for that to happen, it's critical that these older adults have intact functional independence. So I think too often than not, we think, oh, aging is related. It's kind of with these normal functional declines. It's common to lose capacity or ability to care for oneself. And some of that is true. But what my colleagues and I really like to focus on is that no, functional independence actually can be optimized by addressing upstream determinants, including things like regular activity, management of chronic conditions, optimization of sleep-wake patterns. These are all modifiable so that we can enhance functional independence and improve the likelihood that someone can age in place. Unfortunately, when we're thinking about activity, fewer than 1/4 of older North Carolinians actually meet daily activity recommendations. So we live in a state that's full of really fabulous healthcare systems and institutions. And those systems and institutions are also very much filled with talented clinicians. But we know, despite the kind of quality of healthcare that's available to our patients, much of their health actually occurs outside of the clinical encounter at home. And that's especially true for things like health behaviors like activity. We also know that activity levels can change based on pain, mood, fatigue, individual level factors. For any one of us, no matter our age, whether we're young or old or somewhere in between, our activity or our willingness to engage in activity is also influenced by our social environment. Do we have social support? Is there someone that can hold us accountable, motivate us? For older adults, and this was really kind of highlighted by the pandemic and kind of sheltering in place, is one's home environment safe for activity? What about outside of the home? Is it safe for older adults to engage just for something as simple as walking? We also know that any one of these factors can change both within days and across days. And again, we have a talented set of clinicians and healthcare systems, but many of them really lack the time, the capacity, and the resources to one, maybe even get to activity and to gather that information. Some of our older adults aren't always the best historians and most accurate reporters of what they're doing and not doing, but they just don't have the time and resources to understand, and they certainly don't have the time and resources to capture these different factors or to understand the variability. So our proposed solution, again, is PATINA, or patient integrated assessment. So this really leverages passive monitoring through a wearable. So we are using Fitbits at the moment, again, for kind of their accessibility, low cost and whatnot. And that is paired, what's shown here is a smartphone-based diary. This can be done, it's actually a web-based platform, so it can be completed through a smartphone, tablet, desktop computer, or we actually have patients sometimes who prefer pen and paper. So this is our platform, PATINA. I like to just, share. We often, when we present on this work, we'll always get a question, well, older adults, they don't use technology. I'm hoping among attendees, there's kind of awareness that sort of use of technology is certainly growing among older adults. We'll show some statistics from our own patients, but just like to point out kind of the growing and changing trends. And this data is actually from early 2021. So I would suspect these numbers are even higher after going through the tech-heavy kind of few years of the pandemic. So our innovation is probably actually, maybe we shouldn't even call it an innovation. Our innovation really, I don't think I need to share with this audience, is rooted in ecological momentary assessment, or EMA. This is a methodology. Again, the idea is capturing data over time in the real world. This is often done through something like a smartphone. It can also be done through telephone, through interactive voice response. EMA has long been used successfully within research programs, but its integration into routine clinical settings is less common. So again, my team of co-investigators, we together and individually have each used, again, paper and pencil diaries, smartphone-based diaries for, I guess, actually a few decades now. And we have lost count of how many times we are approached, including by clinical teams. How can I use EMA in my clinical setting? I want to know more about what's going on with my patient. As I've alluded to already, kind of the use of daily diaries might help clinics or clinicians better understand those individual social and environmental factors that influence older adults' health behaviors over time. And again, kind of thinking about what is our innovation and what might impact adoption and sustainment. Thinking again, our innovation, I'll spoil the surprise for a next slide or two, is not the actual product or the tool. The innovation is getting it into practice. So we are very much thinking about clinic and system level context and the different factors that you see in front of you. So here we go. Here's the spoiler. Again, our EMA platform is not necessarily what is innovative. We really, I like to think, kind of won this accelerator incubator challenge because we proposed, crazy as it sounds, particularly our system has been going through, we just adopted a new version of Epic. This information from PATINA is actually integrated into the medical record review for both a patient and a provider-facing platform. And then that information from Epic, or the electronic medical record, can be used in routine clinical settings. So we show one clinic or one hospital here. but we certainly know that there are many more that belong to our healthcare system. So we've identified our innovation and kind of started to think, or identified our gap and started to think about our potential innovation and how it might fill those gaps. Next, how can we engage key individuals and end users to explore needs, preferences, and context? So going back to one of our implementation science principles, implementation is multi-level. So here we break down that kind of bottom circle of individuals into thinking about our innovation recipients, our older adults, and our innovation deliverers, our providers. And then both of these groups are kind of housed or couched within clinics and service lines, and then as well as the larger health system and community. So our key questions, our reasons or rationale for wanting to engage these different user groups were, what are their needs, preferences, and experiences? Again, we went to this challenge, this health system challenge, knowing our research team, again, we had lost count of how many teams or clinicians or service lines had come to us asking, how do I get EMA into my clinical practice? We've had high success in kind of uptake of our EMA platforms and research studies, but what might be kind of the needs or preferences of just general patients and caregivers? I feel very fortunate to work in a healthcare system. We're a learning healthcare system where we're small enough that I have really great relationships with several key operations and service line leaders. So going to them and sort of understanding what are your gaps, what are your desires, how might an mHealth tool help enhance your workflow? Again, outside of the research setting and clinical settings, who might use EMA data and how? Is it to guide a clinical encounter? So is a provider reviewing it in advance of an appointment? Are they using it to guide shared decision-making and collaboration with the patient? Or is it simply used to kind of inform additional evaluation and referral for, subsequent follow-up? And then finally, how much training and support might clinical teams need and want to successfully adopt and sustain our EMA tool into routine care? So as we engaged key individuals early in our process, we really embarked on multi-level co-design and user-centered design activities. You see the different levels in the larger teal box. And we really thought about kind of our PATINA platform was built on platforms that my team and teammates had used for many years in a research setting. So we really kind of were optimizing and refining our diary and those EMR kind of based platforms. But we were really thinking about kind of two parallel pathways. One, developing and optimizing our tool, and maybe even prioritizing a little bit more than that, these questions around implementation of how we get, again, our EMA informed kind of modeled program, PATINA, into routine care. So in terms of kind of, so on the bottom right-hand screen, or corner of your screen, you kind of see the CFIR. Again, thinking about kind of that first level, individuals, those receiving the innovation and those delivering it. We engaged in a number of activities. We ask all of our patients, I'm fortunate to have a number of different ongoing behavioral trials where, again, my fabulous research team, everyone they talk to, they have a conversation about their likelihood to use technology as a part of monitoring and modifying health behaviors. We engaged older adults in individual and focus group sessions to hear about their recent experience in healthcare encounters, what was being missed, particularly related to health promotion and function within those encounters, and how do they currently use technology to support and manage their health at home. We did one-on-one interviews with a variety of different providers and clinicians, asking about significant pain points, current clinical priorities, competing demands, and then really asking specifically, here is our PATINA tool. What are your kind of anticipated needs in terms of training, education, and support in order to adopt PATINA, and how would you prefer to have that training and education? We also talked with a variety of clinic and service line leaders. And in this kind of phase, we were really thinking about what are the characteristics of our innovation, again, our EMA platform. How does it compare to what is currently available? Is there anything currently available to assess or get real-time repeated data on health behaviors? What are the thoughts around PATINA's complexity, compatibility, adaptability? Could a provider or a service line leader kind of imagine PATINA being integrated into one system or workflow? There's always question about cost and reimbursement, and how in a system where providers are typically evaluated for their productivity, what does cost of adding something new mean? I kind of talked a little bit at the start about context, so climate and culture, capacity, readiness. We were really keen on understanding, again, we're in a learning healthcare system, so we like to think there's a culture and experience with implementation and quality improvement, but getting a better sense of how lessons learned from prior experiences might impact this current activity. So I won't read these in detail, certainly offer folks who are maybe listening to the recording to kind of pause and read some of these. These are quotes specifically from our clinic staff and our health system leaders. And we were really, really pleased to see, again, we were mainly targeting geriatricians, so folks who are in specialty geriatric clinics. We recognize that we're asking providers to do something else. We are saying we're going to put more data into Epic and ask you to review one more thing. Providers were actually quite excited. So I think just some kind of key highlights from these quotes. The top two is this idea that, we don't have time to talk about health promotion, or we don't see patients for 3 to 6 months or longer. And so we have no idea of what's going on between those visits. And what we really heard from our providers was that it's actually nice to have more data, because then we know what's happening. We can start from a point of data. We're not accusing our patient of doing or not doing something. And it really gives us an idea of what patients want, and we can work towards a kind of shared goal. And I realize I just looked at the time, so I'll kind of pick up the pace a little bit. We talked a lot, I mentioned we're in a really collaborative healthcare system. So we certainly talked with system level leaders as well as payers about, how might remote patient monitoring be reimbursed. And we were very kind of excited through the course of developing and refining our project that there's some pilot work going on in some Medicare Advantage plans to both cover remote monitoring, but also to start looking at wellness coaching as part of these plans. So I've alluded to this a little bit. We're a really large system. Our system, we are now covering the Southeast as well as the Midwest. Atrium Health is kind of the Southeast market. Advocate Health was the Midwest market. Now we're Advocate Health as a large system. This means we have more than 1,000 sites of care and see more than 6 million patients. So all of these changes and expansion were happening during the development of our project or our program. And so we're always thinking about, okay, this is the scale that we're going for. So 1,000 sites of care, there's going to be a tremendous amount of variability. 6 million patients, there will be tremendous amount of variability in our patients and our clinics, and kind of thinking about how does that variability impact scale and sustainability. So as I mentioned, I'm a big fan as an implementation scientist of cultivating collaborations very early on. I won't go into detail about our different team. I'm really fortunate to work with some talented folks who are also a lot of fun. Our Center for Healthcare Innovation is an innovation center, as its name suggests. that's really focused on how we scale evidence-based practices to improve care in a rapid and effective way, with a primary focus on technology. So we have a number of different academic partners, as well as clinical partners, and a population health management is a really big primary supporter of our work. So developing and refining your innovation. Again, this is probably where many of us kind of thrive. What are the details, the technical specifics of our mHealth tools? So this audience probably doesn't need kind of much introduction to what we can, the kind of capacities and capabilities of EMA tools. So passive monitoring, we're looking at steps, so activity and inactivity and extended periods or bouts of sedentary time. But we're really, again, we're interested in kind of those contextual factors. Individuals, what are they doing when they're sedentary? It could be good sedentary. They're socializing, they're reading, or is it unhealthy sedentary time activities? What we've really introduced into our platform is building off of the age-friendly initiative, really kind of identifying what matters most for older adults and making that a key component of then what gets fed back into the medical record for our providers to not only see this data, but to see that patient's goal before they see the data, and then work side by side with the patient to impact activity and achieve that goal. These are some very preliminary from our very, very early development stages, some examples of our kind of provider and patient-facing feedback that is integrated into the medical record. So the idea is we heard from providers, some said, oh, give me all the data, I want to play with it, I want to look at it. And then other providers said, no, I just want a summary. So we are actively working on how to provide both. But the idea is showing trends for both providers and patients. So the top is kind of orienting a provider to see that this patient, Mr. Smith, is more active when there's less pain and more social supports. So how to leverage those different components, let's say, into an action plan, and then encouraging a patient to follow a regular sleep schedule. So I'll kind of leave these slides for you to maybe review at a later point in time. I think, you know, really the data that we have from our project that we can also kind of highlight to some of our clinical and operations partners is that contextual data that's drawn from PATINA or from the diary. A third of our older adult patients live alone. More than 3/4 of them are spending the majority of their time at home, often alone. So what does that mean for activity recommendations? And then we saw a lot, not a lot of exercising, but a lot of kind of more common hobbies. So again, kind of what do these findings tell us, our team, in terms of what sort of training or recommendations we give to providers on how they might engage older adults in increasing their activity? We've gone through some preliminary usability testing, very pleased with high acceptability and feasibility, including, and I also mentioned some pretty in-depth exit interviews. So I think quickly just I'll orient you to the quote on the bottom of, you know, we were pleased our providers want this information. Our patients were even more excited that we are actively working on how to kind of get information from them, relay it back to their provider so that hopefully their provider can kind of, you know, see them in a little more holistic kind of perspective. And finally, I'll just close the last few slides with kind of how do we evaluate the innovation, as well as kind of those key implementation activities. So we are anxiously awaiting on a funding decision. We've had some very preliminary promising site visits from a foundational partner to pilot a care model in collaboration with key operations leaders and health system clinics. So I won't reveal, since we are kind of moving into a testing phase, but kind of main elements of that care model, we use a risk stratification tool to identify who might benefit from PATINA. We provide in-depth implementation support to our primary care providers on how to use PATINA, how to make referrals if their patient might benefit from more further assessment or care. technical assistance, both for patients and providers in using PATINA. And then again, thinking really closely, our Office of Population Health Management is a big supporter of our work, so involving them throughout the process of how we might scale up this program. I'll leave you to kind of refer back to some of our evaluation metrics, and just in take home, again, kind of thinking about these key points or principles from implementation science. It's dynamic, it's multi-level, it's an iterative process. Leveraging some of these principles and defining and refining our mHealth tools can have a number of different benefits. And sometimes our innovation in mHealth is less related to the tool itself. In our case, EMA, it's been around forever. There's nothing too fancy or innovative about our PATINA program. But really what is innovative is trying to get this long-standing tool of ecological momentary assessment into routine clinical settings.